Very happy to see you. I'm going to change the sequence of speakers based on the availability because there's a film festival going on and majority of my speakers are sitting there. And that's how, so I'm going to call her because he's Fakey Kayol. So I thought I'll finish hyperopia with Sundarya. So I'm going to inviting my next speaker, Dr. Sundarya, who's a young consultant cataract and refractive surgeon from the Eye Foundation group of hospitals and an amazing speaker and a very talented girl. And she would be talking on hyperopic corrections, options and precautions, preferred practice guidelines. On to you, Sundarya.
Thank you, Dr. Chitra ma'am, for this opportunity. So I'm going to be talking about the options and precautions for hyperopic correction. So as we know, hyperopia is not as common as myopia, where 30% of the population are myopic in our country, only 3% are hyperopics. So one thing that we need to know before going into this is classifying the hyperopia to decide what kind of treatment would be appropriate for each. So we have the low hyperopia less than 2 diopters, then 2 to 4 diopters, and more than 4 diopters. So the basics of treating hyperopia, the main thing is to aim at a stable refraction and topography before proceeding as with any laser refractive procedures. And again, the age of treatment more than 18 years and not progressive. One thing we need to remember is as the patients become older, their accommodation goes down. So we need to keep that in mind and explain it to the patient as well. And they often have concomitant astigmatism, so that also has to be taken care of. So one thing, another main important thing is the thorough cycloplegic refraction that has to be done with homatropin before proceeding with the cases, because the problem with hyperopic correction is more of an undercorrection than the regression that happens. So, and we need to correct the maximal acceptance and correct only if the difference between the acceptance and the cycloplegic values is less than 1 diopter. Another thing is the anisometropic amblyopia and squint, which is not very uncommon in hyperopic patients. So this becomes one of the indications to correct patients less than 18 years of age as well. So here, before going ahead with the vision therapy and the squint surgery, it is better to treat the hyperopia first, give them similar sized images in both eyes, which would enhance our success with vision therapy. So what are the various options available? We have the laser vision correction, which would be the flap-based and the surface ablation procedures. And we have the tissue additive procedures. We have the phakic intraocular lenses, be it monofocal or presbyopic lenses. And finally, we have the refractive lens exchange. So when we're talking about laser refractive correction for high hyperopia, the major issue, as I told already, is the undercorrection. And another thing we need to keep in mind is an initial postoperative myopia is always okay and it will subside with time. And it's less predictable wound healing is there here, and the biomechanical response is also erratic. So regression chances are always there. And the poorer quality of vision when we steepen the cornea too much again is going to be an issue. And because of the over steepening, ocular surface issues are also going to be there. Just an example showing how the mid-peripheral flattening happens, which causes an indirect steepening in the center. So any keratorefractive procedure for hyperopia is going to become less predictable beyond 3 diopters, because it's more difficult to predict an indirect steepening of the cornea rather than the direct flattening that happens in a myopic treatment. So, and again, another limiting factor is the Kmax of anything beyond 48 is going to be a difficult issue, because every diopter of correction steepens the cornea by 0.6 diopters, which we need to keep in mind while planning the procedures. And as I already told, a hypoprolate cornea is going to predispose to ocular surface issues as well. So the EX500 can correct up to a +6 diopter of hyperopia and a 6 diopter of cylinder. And here we need to keep in mind to have larger flaps and a larger optic zone. And in patients with large angle kappas, we can also manually center the vertex using the images from the topolizer. And as with Contura, it's already centered on the visual axis. Just a few words regarding SMILE for hyperopia. It was first investigated in 2010, and they used a lenticule of 7.5 mm, and which was thinner in the center and thicker in the periphery. And the initial results showed regression and drop in BCVA. However, if we are able to provide improved normograms, a larger transition zone, and optimized energy, SMILE may as well become a good option for hyperopia. Few words regarding the tissue additive procedures which are being tried right now. So we have the SMILE lenticules that can be added into pockets. So the advantages would be that it provides a more physiological shape than what is a result of a laser refractive procedure. And there have been no reported rejections, and it's also a reversible procedure. However, we definitely have the disadvantages of it being less predictable, just like the laser procedures. The chances of undercorrection and regression are always there. And the unique difficulty challenge here would be the lack of availability availability of similar donor tissues. So when we're talking about high hyperopia, again, as with according to the patient's age, we can decide. If it's less than 45 years, phakic IOLs would be the choice. With more than 45 years, lens-based procedures would be ideal. And any patient of any age with AC depth less than 2.8 mm, obviously lens-based surgeries are going to be more preferred. So the advantages of phakic IOLs would be better predictability and faster visual rehabilitation, a more stable refraction, lesser incidence of dry eye, and a better visual quality. And the phakic IOLs in hyperopia are biconvex, so they're thicker lenses. That's something we need to remember. And they're going to increase the angle by 10 degrees. And the ICLs don't have a central hole, and the more thickness is going to result in light scattering and dysphotopsia. And up to 15 diopters can be customized with the IPCL. So just a few words regarding the presbyopic phakic IOLs. They are trifocal diffractive lenses which can provide up to plus 1.5 to plus 3.5 diopters at the lens plane. So coming to the clear lens exchange, so as we know, even before cataract develops, the lens dysfunction begins. So as the aging happens, the spherical aberration is going to increase, the light scattering, the refractive index, the size of the lens is also going to increase, whereas the transparency and the accommodation start coming down. So now why is clear lens exchange becoming a more preferred option? Because we have better accurate biometry, excellent post-surgical visual outcomes, the availability of premium lenses, and the active lifestyle of patients beyond 50 and the desire to get rid of glasses are also there for the patients. And it's going to be effective with careful counseling, meticulous evaluation, and flawless surgery. We can end up with satisfied patients. And obviously with shallow AC, lens extraction is going to be more preferable. As with myopia, there's not going to be an increased risk of retinal detachment and the minimal induction of higher order aberrations. And but the only challenge here is in higher hyperopia, chances of choroidal effusion are always there. In extreme hyperopia, up to 65 diopters has been customized, and we can always go ahead and put a piggyback lens as well. So just to summarize, a younger patient with a refractive correction of +3 or lesser, definitely laser refractive or keratorefractive procedures are a choice. So anything beyond that, patient less than 45 years, phakic IOLs would be the choice to go. And if the anterior segment parameters are normal, and beyond 45 years, clear lens exchange is always an option. Thank you.
That was a wonderful talk, Sundarya, and I would want my speakers to stick to 6 minutes and 2 minutes discussion. Sheetal could connect her slides. One question which I'm going to ask Dr. Dhami and Somshila, even if they differ. The patient is very desirous of great visual quality, and would you think of a laser vision correction or a phakic IOL to this patient in this hyperopia? Hyperopia is a talk. What do you have to say, Sri Ganesh? Sorry, Somshila, he was vigorously nodding his head. I wanted to know something.
In young patients, they lose accommodation.
Yes.
And also there's a lot of induction of aberrations,
Yes.
which cannot get corrected because you removed the natural crystalline lens. I would do tissue addition, and that's what I've been doing for...
No, you have to reach out something to the audience, please. My audience need to know the answer. We don't want some very new advanced procedure.
For up till 4 diopters, you
Yes.
can do LASIK. Smile will be available shortly, that commercially. But those who have access to Smile can do tissue addition.
Yeah.
Shreyas has done.
Yeah, I agree. But smile, everybody is not happening because we can't. We have to send them right messages at this.
Between 4 to 9 diopters, okay, there is no corneal procedure right now except tissue addition. And that works beautifully. Patient can still maintain their accommodation. We have a 8-year follow-up. Patient's doing very well. Refractive lensectomy for a very young patient, not very desirable. Young patient. If they are over 45, then it's okay. You can do it.
Okay.